Coming to deglutition, it refers to the passage of food from oral cavity into stomach. Again, it is a reflex response that is triggered by afferent impulses in the 5th, ninth, and 10th cranial nerve. These impulses are integrated in the nucleus of tract solitarius and nucleus ambiguous. The efferent fibers pass to pharyngeal musculature and the tongue via 5th, 7th, and 12th cranial nerve. The deglutition has three important stages, that is oral phase or buccal phase, pharyngeal phase, and third one is esophageal stage. Oral phase. Oral phase is a voluntary stage. The food passes from mouth to the pharynx here. This phase includes voluntary placing of food and rolling of tongue. This backward and upward movement of the tongue presses the food against palate and bolus moves from mouth to the pharynx. Pharyngeal phase. It constitutes passage of food through the pharynx into the esophagus. It is an involuntary phase. As the bolus of food enters the posterior part of the mouth and pharynx, it stimulates sensory receptors located in these areas. This will initiate reflex contraction of pharyngeal muscles. Once the food is in oropharynx, there are four possible outlets for food. First, it can go back into the mouth. Second one, to the nasal cavity. It may enter into the respiratory tract, or it should go to the esophagus. The entry of food into the mouth prevented by approximation of the tongue against the floor of the mouth. Soft palate is pulled upwards to close the posterior ears, which prevents the reflex of food into the nasal cavities. Paratopharyngeal folds are pulled medially to make a slit-like opening through which the food must pass into the posterior pharynx. The slits perform selective action, allowing only the properly masticated food to pass through. Vocal cords are strongly approximated, that is, stopping the breathing temporarily, which is called as deglutition apnea, and the larynx is pulled upwards and anteriorly by the neck muscles. Epiglottis swings backward to close the laryngeal opening. All these guides the food towards the esophagus and prevent its entry into the trachea. The upward movement of the larynx also pulls up, enlarges the opening of esophagus, and upper esophageal sphincter relaxes, thus allowing the food to move easily from posterior pharynx into upper esophagus. This sphincter remains strongly contracted in between swallows to prevent entry of air into esophagus during respiration. So these are the different stages: the oral stage, the pharyngeal stage, and the esophageal stage. Where in oral stage, from the mouth, it is going to enter into the oropharynx, and in the pharynx, the food is going to and from the oropharynx into the esophagus by reflex activation, where the food cannot enter into the nasopharynx bag, it cannot enter into the trachea because of the closure of laryngeal inlet, and also the epiglottis makes a way for the food from the oropharynx into the esophagus, and in between there will be deglutition apnea as well, which is going to stop the respiration for a while. Entire muscular wall of pharynx contracts, that is, beginning in the superior part, then spreading downward over the middle or inferior pharyngeal areas, which propels the food by peristalsis. That is, it is a reflex response that is initiated when gut wall is stretched by the contents of the lumen, and it occurs in all parts of the GIT from esophagus to the rectum. And ultimately food is brought to the esophagus. The entire process of this stage occurs in less than 2 seconds. Coming to esophageal phase, during this phase, food bolus is propelled from upper part of esophagus to stomach. It is involuntary stage again and exhibits two types of peristalsis, that is primary and secondary peristalsis. Primary peristalsis, it is the continuation of the peristaltic wave that begins in the pharynx and spreads to esophagus during pharyngeal stage. This wave passes from pharynx to stomach in 8 to 10 seconds. Secondary peristalsis. When primary peristalsis fails to empty the bolus into stomach, the retained food initiates secondary peristaltic waves due to the distension of esophagus. The second waves are initiated partly by intrinsic neural circuits in the myenteric plexus and partly by reflexes that begin in the pharynx. They are transmitted upward and through afferent fibers to the vagus, uh, afferent fibers of vagus to medulla and back again to esophagus through 9th and 10th cranial nerves. When peristaltic wave reaches the lower esophageal sphincter, it relaxes and allows the food to enter the stomach. And this relaxation is mediated via neurons that release nitric oxide and VIP. Some of the disorders of swallowing. Dysphagia, nothing but difficulty in swallowing. Achalasia is a condition in which food accumulates in the esophagus. Esophagus is massively dilated. It is due to the increased resting lower esophageal sphincter tone and incomplete relaxation upon swallowing. The myenteric plexus of the esophagus is deficient at the lower esophageal sphincter in this condition, and the release of nitric oxide and VIP is defective. It can be treated by pneumatic dilatation of the sphincter or incision of the esophageal muscle, that is also called as myotomy. Inhibition of acetylcholine release by injection of botulinum toxin into the lower esophageal sphincter is also ineffective and produces relief that lasts for several months. Gastroesophageal reflux disease. It refers to a condition in which there is a reflex gastric contents into the esophagus. There is a reflux of gastric contents into the esophagus. It is due to the incompetence of lower esophageal sphincter. This reflex causes heartburn and esophagitis and can lead to ulceration of esophagus. Aerophagia. In some people, especially nervous people, swallow large amount of air. Some air is regurgitated by belching, and some of it is absorbed and rest reaches the colon and it is expelled as a flatus. In some individuals, gas in the intestine causes cramps and borborygmi, that is rumbling noises and abdominal discomfort.